important today. So trauma-informed care is all about shifting your perspective from a thought of what's wrong with you to what happened to you. So it's about bringing humanism to the medical field and recognizing that our experiences shape how we behave. So why does it matter? So in social work and in mental health, trauma-informed care has been a major topic for many years. More recently, it is a major focus in our leading trauma care organizations. So last year, the ACS added trauma-informed care to the ATLS, and it was a major focus at the TQIP conference in 2025 as well. So a lot of the information that you'll see here today in the presentation is actually pulled directly from those new chapters in the ATLS. So I want to kick off the topic with this brief video, which really highlights what trauma-informed care is all about, which is that there is maybe something going on under the surface with everyone we interact with in the healthcare setting that we know nothing about and we maybe can't see. So, as you saw in the video, people around us are going through things that we know nothing about. So, you may be meeting somebody on the worst day of their lives and not know it. So, with the trauma-informed care framework, we assume that patients may have experienced a trauma, and we want to protect them from any re-traumatization. So, this requires us to consider ourselves, our families, um, patients, family members, visitors, and really everyone that we interact with in the healthcare setting. So, trauma-informed care breaks down into 6 key principles that we'll talk about throughout today's presentation. So, first, it's about creating a safe environment, both physically and emotionally for our patients, being aware of our communication and developing trust through our communication and providing opportunities whenever possible for patients to have choice and autonomy, and collaborating with our teammates and supporting each other as healthcare teammates, of course, and always being aware of any biases. So remember that you don't have to be a therapist to be therapeutic, and trauma-informed care is all about building a trusting relationship. So meet Danielle. She is based on a real patient that was here at CMC. We've changed just a few minor details, but we are going to be referring back to her, checking in with her throughout the presentation. So Danielle is a 29-year-old Black single female presenting to the ED after a high-speed MVC. She sustained a femur fracture, liver laceration, kidney laceration, and of note, she did come in positive for marijuana use. So consider Danielle as we move through the presentation. I'll turn it over to Chloe to talk more about the way trauma shows up for our patients.
All right. So now I'd like to shift us into a topic that directly, shapes the patients that we're seeing every day, which is social determinants of health. So my question for everybody to start off is think about how often and how much attention you're paying to the family and social history of a patient. This may be through the family and social history box on a chart. For a lot of us, it's something we may skim past. We're more focused on the mechanism of injury, the patient's labs and imaging, and understandably so. But that information in the family and social history box holds important context for patients. And a major goal of trauma-informed care is to make the person that we're serving human first, and considering a patient's social determinants of health is a huge part of that. So this graphic here comes from the Kaiser Family Foundation, and it breaks social determinants into 6 domains. So we see economic stability, neighborhood and physical environment, education, food, community and social context, and healthcare system. So each of these domains affects a wide range of health outcomes. And what research tells us is that when a person is dealing with multiple adverse social determinants, the health impact is big and outcomes are worse. So when we talk about reducing harm and improving outcomes for patients, addressing social determinants of health is where a lot of the most effective solutions lie. So this graphic here from the American Hospital Association really drives this point home. So take a look at the impact on the far right. It tells us that 20% of a person's health and well-being is related to access to care and quality of services. And this is the part that we really tend to focus on, the more clinical piece. But it says afterwards that the physical environment, social determinants, and behavioral factors drive 80% of health outcomes. So what this means is that we can provide awesome healthcare like we do, but if we only focus on that, we're missing a huge piece of a person's life. We're only addressing a fraction of what it takes to help a patient get better and then stay better. So here's another quick video. This goes over adverse childhood experiences, or ACEs, and also toxic stress.
Adverse childhood experiences, called ACEs, are stressful or traumatic experiences that occur in childhood, like violence, abuse, and growing up in a family with substance use or mental health problems. When a caring adult or supportive environment doesn't soften those adverse experiences, or when they are ongoing or overwhelming, they can lead to a prolonged activation of our stress response called toxic stress. Think of toxic stress like this. Our bodies were designed to escape predators quickly. Imagine you're walking through the woods and you see a bear. Your brain signals your body to release stress hormones like adrenaline and cortisol. Your heart begins to pound and your body prepares you to either fight or run from the bear. And that's useful if you're in the forest and there's a bear. The problem is when children face threats to their physical and emotional safety, and this system is activated over and over and over again. What was meant to protect you begins to do the opposite and becomes damaging to your health, creating long-lasting wear on your body and brain. Children are especially vulnerable to the effects of ACEs and toxic stress because their brains and bodies are still developing. The toxic stress from ACEs and other adversities such as poverty, racism, discrimination, and natural disasters can disrupt the normal functioning of vital bodily systems. Simply put, toxic stress can result in long-term mental and physical health conditions. Not only that, but the effects of ACEs can be passed from parent to child for generations through the biological changes and behaviors associated with ACEs and toxic stress. A person with 4 or more ACEs is twice as likely to suffer from heart disease, cancer, and stroke, 4 times as likely to develop depression, and 12 times as likely to attempt suicide. The good news is that safe, stable relationships and environments and other interventions such as physical and mental health support can reduce the risk of ACEs leading to toxic stress and stress-related health conditions. To learn more, visit www.osg.ca.gov.
All right. So like that video explained, ACEs are adverse childhood experiences, and they are grouped into 3 categories, which are up here on the screen: abuse, neglect, and household dysfunction. And though these experiences happen in an individual's childhood, they have a profound and lasting impact on health throughout the entire lifespan. So here's a piece of adverse childhood experiences that really matters. They are incredibly common. 62% of adults in the US have at least one ACE, and then a quarter of US adults, 25%, have 3 or more. So when you consider that, we are coming into contact with individuals with ACEs constantly. It's not an occasional thing. This is a constant encounter. Our patients, yes, are those individuals, but also our coworkers, our friends, our family, and potentially even ourselves. This is the majority of people that we're interacting with, not a niche population. So the impact of ACEs is significant, like the video began to share. This graphic here shows the cascade of concerns associated with ACEs. So on the behavioral health side, we have things like lack of physical activity, substance use, missed work. And then on the physical and mental health side, we're looking at severe obesity, diabetes, depression and suicide attempts, cancer, stroke, and even broken bones. So that connection of childhood adversity and long-term health outcomes like these is one of the most well-documented findings in public health. And for us as healthcare professionals, it means that many of the patients that are coming through our doors that we're interacting with are carrying years of accumulated impact before we even meet them. So let's check back in with our patient, Danielle. At admission, a provider documented a social determinants of health screening for her. And this is what it shows. As you can see, it was marked low risk for living situation, food, transportation, utilities, and depression. So on paper, based on just this screening alone, Danielle looks like she's doing all right. Everything is flagged as low risk. And if this is all we had to go on, we may move on without giving it much of a second thought. But look what happens next. So while Danielle's still in the emergency department, a chaplain comes and visits her and spends some time with her, and Danielle begins to open up some more and share a bit of a different picture. This is where she shares that she's experiencing high levels of anxiety and depression. She reports no social support. She's experiencing homelessness. She's deeply stressed about what will happen at discharge. Where will she go after this? How will she pay for this? And then she also shares some trauma history, starting from childhood, which those are her ACEs. And more recently, she shares that she lost her children and her partner in a house fire just 2 years prior to admission. I want you to sit with this for just a moment and think about the Danielle that we met on that first slide. A 29-year-old woman, she was in a motor vehicle collision. She has a femur fracture, positive UDS, and then think about this Danielle that's unfolding now. My question for you to consider is, how does this new information change the way that you see her, and how does it change the way you may approach her care in whatever field that you are in? So we are going to try this fun poll. So if everyone could get out your phones and scan this QR code, you can also join at menti.com and use this code here. And as you enter your answers, they should start popping up on the screen. So we can see, again, how might this new information change the way that you see Danielle and approach her care. Spend more time with her, more compassionate, patience. Yeah, absolutely. Lots of barriers are present to her recovery. Biases. Sure. Some. Yeah, would enable me to connect with her on a deeper peer-to-peer level. Awesome. You can keep throwing your answers in there, but thank you for providing those answers. That important shift of viewing her as a human with real life experience is the heart of what we're talking about today. So thank you. We will move along. Actually, before we move on, we'd like to note that we were not sure why there was a low-risk screening documented to begin with. There are many possibilities as to why that might have happened. It may have been checked off and not actually done. The chaplain may have offered Danielle a safer space to share these things. It may be both of those things or none of those things, or something that we haven't considered. But what's important is that there was a safe space open for Danielle to share this important context about her situation and herself. Okay, so this iceberg graphic here, you may have seen it before. This captures this perfectly. So what we see as clinicians, as nurses, as techs, as anyone interacting with patients is their behavior, the top of the iceberg there. That's things like anger and noncompliance, running away, self-harm, lying, and those are things that show up on our radar that we see and frankly can be frustrating and difficult to deal with in a clinical setting. But what's underneath, what's hidden, is the trauma. So those are feelings of being worthless and alone and rejected, unsafe, ashamed that they're a bad person, that the world is unpredictable, that no one can be trusted. Traumatic injury is actually another example of that trauma that we're talking about. A traumatic injury can bring up things from the past, new negative feelings, things like that. And if we're only responding to what's above the waterline there, that top of the iceberg, we're missing the whole picture of the individual. And we're also more likely to respond in a way that actually makes things worse. So let's talk about why this happens on a neurological level, because this is important context, especially for a room with lots of people who think more in terms of physiology. So experiencing ongoing trauma literally can change the brain. It can alter a person's ability to know what they're feeling and manage their emotions, manage stress, work toward goals, develop and maintain healthy relationships. And if you look at this brain graphic to the right, we learn that the prefrontal cortex, which handles rational thinking and emotion regulation, it actually shows reduced volume with PTSD. And similarly, the hippocampus, which is responsible for memory and differentiating between the past and the present, actually shrinks with consistent trauma exposure. And then the amygdala, which is wired for survival, becomes hyperactive with trauma. And when the amygdala is firing, it is very hard for someone to think rationally. So when a patient seems that they can't make logical decisions or they can't regulate their emotions, it's not that they won't do this. Many times their brain has been physically altered by their experiences and they're operating from a survival state. So with that brain science in mind, let's look at some of the behaviors that we are commonly seeing in our fields. And I want to draw your attention first to the quotation marks around maladaptive. That is intentional. We are not labeling these behaviors as inherently bad or pathological. These quotes signal that these behaviors are actually often adaptive strategies that were shaped by a person's past trauma history. And they may seem challenging or hard to understand in your setting, but they do usually serve a purpose. So if these behaviors aren't just bad behavior, what is behind them? So behaviors that seem hard to understand on the surface often do make complete sense in the context of a person's trauma history. They follow a logic, they serve a self-protective function, and behind them there are often very normal, very healthy needs, like the need to feel in control, especially in an environment like the hospital where so much is out of our control, the need to feel safe, the need to understand and find meaning in what's happening to them. So the shift that we're asking for here in trauma-informed care is moving from asking, why is this patient being so difficult, to asking instead, what is this behavior trying to achieve? Or even simpler, what does this patient need? That's the shift from responding with frustration and judgment into instead responding with empathy and skill. And I want to be clear, this doesn't mean excusing harm. It means understanding where that behavior is coming from so that we can respond to it more effectively. So you may already be familiar with this framework, the 4 Fs of trauma responses: fight, flight, freeze, and fawn. Fawn is one that people are less familiar with. I was less familiar with this one. It looks like identity confusion, lack of boundaries, codependency, and people pleasing. So when a person experiences trauma, their nervous system activates one or more of these responses. You yourself might fall under one or multiple of these, and your patients might as well. And recognizing which response your patient is in that moment can help you understand what they need from you. Someone who's in fight mode needs something very different than someone who's in freeze mode. So this is a really important slide because it gets at something that we all have likely dealt with: a patient who doesn't engage in discharge planning, keeps showing up in the emergency department time and time again, a patient who struggles with medication adherence, who doesn't follow their care plan. And I think the natural human tendency is to think this person isn't trying or they don't care about their own health. But the reality is that these barriers are often rooted in systemic factors, not individual choice. Things like poverty, housing instability, economic challenges, lack of resources in general. These are structural inequities that work against our patients every single day. For example, a patient may refuse a dose of medication. This may be taken as an irresponsible choice to not follow their treatment plan, but in actuality, this may be happening because they're worried about having to pay for this medication after discharge and not being able to afford that. By seeing these barriers as external and systemic rather than a personal failing, we can approach care with empathy, we can collaborate more effectively with patients on realistic solutions catered to them. We can stop blaming them for circumstances that are largely outside of their control. And this is a core piece of trauma-informed care. So let's check in with Danielle again. It is now day 3 of her admission. And for Danielle, this is not just any day in the hospital. This is the anniversary of the death of her children and her partner. And on this day, she begins having multiple panic attacks. She begins refusing services. She makes concerning statements about her sense of self and the future. Psychiatry is consulted and provides her some supportive counseling and prescribes her medicine for her anxiety and depression. But here's where I want to focus your attention, is that third little bullet point in there. A provider note in the chart states, patient refusing necessary care without clear medical reason, appears uncooperative. Now, knowing what we know about Danielle, how does that note land? That doesn't capture context. It doesn't reflect what's actually happening. It frames Danielle as a problem. And this really matters because documentation becomes a patient story in the system. It shapes how every future provider will understand them. When notes use language like this one, like uncooperative or non-compliant or difficult or manipulative, that framing follows the patient for the rest of their time in that system. It increases stigma toward them. It can escalate staff response. It can increase coercion. It can overall decrease patient autonomy. And that can also lead to re-traumatization for the patient. Trauma-informed documentation instead provides context rather than judgment. It protects patients because notes don't just explain what's happening in the patient's time in the hospital, they shape what happens next throughout the rest of their medical journey. So let's talk about re-traumatization because this is something that can happen in our settings without anyone intending it or even knowing that it's happening. Re-traumatization in medical care means unintentionally replicating feelings of powerlessness, threat, or lack of safety. So essentially reminding someone of past trauma through the way that we're delivering our care. So on the system level, this can look like protocols that don't offer choice, like a fixed treatment order with no discussion with the patient, asking a patient to retell their story time and time again to multiple different providers. That can feel like they are reliving their trauma over and over again. Large impersonal systems that make people feel more like a number than a person, or even elements of personal space. So think about coming to the hospital, being removed of your clothes that you came into or came in with, put into a gown, coming in and people coming in and out of your room with little to no warning, being poked and prodded with not much of that in your control. For someone with a trauma history, this can feel deeply exposing and unsafe. And then on the relationship level, a provider doing things like offering a solution before actually listening can violate trust and feel dismissive. Like we talked about with documentation, labeling someone as non-compliant or an addict or a schizophrenic, things like that. Those labels repeat themes of being misunderstood or judged. Acting for someone rather than with them can recreate those feelings of loss of agency. And then ignoring or minimizing patient concerns that are brought to your attention, not acknowledging that discomfort or worries or past experiences, that can make someone feel unseen and unsafe in an already difficult environment. The takeaway here is that trauma-informed care actively reduces these harms by instead building collaboration, transparency, choice, and emotional safety into our everyday practice with patients. So what does this actually look like in practice? Let's talk about communication specifically. So the overall goal is to listen without pressure. Trauma often teaches people that speaking up is unsafe. So giving them ample time and space really matters more than we might think. Don't rush them. Don't try to fill every sentence. If someone becomes emotional, our role is to stay present and stay calm and to validate them, not to fix or redirect their feelings. It can be really tempting to jump in with a solution that seems really obvious to you, or try to move things along to see the next patient. But sometimes the most powerful thing you can do is just spend a minute being there with them. And reassurance doesn't mean minimizing their situation. Saying you'll be fine or it's not that bad is indeed not reassuring. That is dismissive. And real reassurance means showing that you care and that their environment is safe. Offering choices to them when possible, using open-ended questions, offering affirmations, and normalizing their reactions within the context of their history. And be careful not to diminish their experience. Some phrases that are very well-intentioned, like you're relatively lucky in this case, can shut somebody down. Even silence or just supportive presence can communicate safety and validation to patients. You don't always have to have the right thing ready to say. Sometimes just being there is enough. And like Kayla mentioned at the beginning of the presentation, collaboration is a core principle of trauma-informed care, and this applies in this case as well. If you can't provide the time and services needed, then who can? Who around you can provide this? This may be a different team, a coworker that you know connects well with that patient or patients in general, things like that. So know your resources when communicating. So here's part of the payoff with trauma-informed care. So trauma-informed care doesn't just help our patients, but it helps us as well. So like we've talked about throughout this presentation, on the patient side, trauma-informed care promotes autonomy, it decreases helplessness, improves communication and trust, it values the individual, promotes validation and understanding, and these are all things that make a patient feel more like a person and less like a case number. But then on the provider side, trauma-informed care decreases frustration because when you understand where a behavior is coming from, you're less likely to take that personally. It improves empathetic communication. It raises awareness of biases that we might not realize we're carrying with us. It improves job satisfaction overall because when you feel like you're providing care that actually reaches people, that is very meaningful. And that's the kind of work that keeps us going in this field. So let's come back to Danielle one last time. We have walked through her story across this presentation, from the initial admission information to the social determinants of health screening, to her trauma history, to how her stay unfolded in general. And I think Danielle's story shows us how much context matters and how much of a difference is made when that context is incorporated in the way that we deliver our care. So like Kayla said in the beginning, trauma-informed care does not ask us to be therapists. It doesn't ask us to solve an individual's trauma history. What it asks is that we pause long enough to consider what is underneath the behavior that we're seeing, that we build small moments of choice and safety into the care that we're providing, that we think about how our words and our documentation, for example, shape the story of a patient throughout the entire system. And I want to leave you with this phrase, because I think it captures something really important. Anger is sadness's bodyguard. So when we see anger or resistance or withdrawal or any of those behaviors that we saw at the top of the iceberg a few slides back, there's almost always something deeper underneath. So this pie chart to the right here shows a few examples of that. So fear, loneliness, depression, shame, hurt, things like that. And our job is not to fight the bodyguard. It's instead to recognize what it's protecting. Actually, we do have a poll. I just realized. We have another fun poll. Okay, a little frozen. We did have a poll, or not. Oh. Just sharing. Yeah, we'll just read. Sweet. Okay, so just like the last one, you can, if you're already in it on your phone, it should have already popped up. If it didn't, though, there's the QR code. So just would love to hear a few blurbs about what you've learned from Danielle's story, all of those check-ins with her. Yeah, lots of chapters in her story. The root cause of the behavior needs treatment as well as physical trauma. Absolutely. Every patient has a story to tell, and I should take the time to listen to it. Understanding what's beneath the anger. Listen to the chaplain. The importance of words sets them up for more trauma. Don't assume appearance can be deceiving. Absolutely. Thanks for throwing those in there. Okay.
Did it again. Yeah. Okay. So we talked a lot about Danielle, but we also want to feature another story, another case where trauma-informed care is really important. So sometimes when a patient presents with a lot of good social support, they're really appreciative of their care, they're very kind and have a good, present with a good mood, we might assume that they're okay. So here's a bit of information about Richard that you might learn from initially reading through the chart and a first visit with him. So he's a 76-year-old male admitted after an MVC. He came in with clavicle fracture, scapula fracture, rib fractures, and injury to his previously reconstructed knee. Of note, 27 years ago, he had another trauma where he was a pedestrian struck, leading to an incomplete spinal cord injury. Last year, he went through lung cancer treatment, and he has a wife of 52 years and 6 children who are really supportive and live locally. You might meet them when you enter the room. Richard is very friendly, very jovial, but he does tell you he's having some anxiety. So consider your role and how you may interact with Richard and think, is there anything you would want to ask him? And what do you think could be contributing to his anxiety? We're going to do one more poll. Yeah, the previous MVC, it's compounding trauma, past experiences, PTSD, fear, loss of control. That's big. And hospital anxiety. Those are all great. Thank you for contributing. So what the chart doesn't tell us that we learned in our bedside counseling session with Richard is that he is a veteran, which comes with its own trauma history. He's really advocating for himself to go to acute rehab because he doesn't want to be a burden to his wife, who's already been caring for him the last 27 years with his spinal cord injury. He lives with high anxiety about his cancer coming back, and being back in the hospital setting doesn't help. He's frustrated that he developed cancer last year because he spent a lot of time put a lot of effort into stopping smoking many years ago. And now, on top of everything, he had a knee reconstruction last year that he's worried needs to be redone, which will add to his recovery and his overall stress. So just consider how this additional context impacts your perspective of Richard, and how do you think these layers of his trauma are impacting him here? So this one, just think about it, reflect. So how does this impact staff? So trauma-informed care not only impacts patients, but also staff. It's all about shifting the healthcare culture from resistance, pushing through, suppressing emotions, ignoring any warning signs of stress, to resilience, adaptive regulation, emotional processing, setting healthy boundaries, and utilizing your support system. So resilience is all about operating within what's called your window of tolerance. So recognizing when you may be angry, panicked, or overwhelmed. That's a hyperarousal state. Or withdrawn, shut down, or numb. Those are the hypoarousal states. And identifying warning signs that you are not within your optimal mode, where you can feel calm, alert, and thinking clearly. So nearly half of healthcare workers in 2023 reported burnout. So trauma-informed care is a preventative and protective framework for staff well-being, not just for patient care, but staff well-being impacts patient care. So how does all of this impact us as trauma professionals or healthcare providers? So trauma-informed care is the umbrella here that protects us from all of these impacts. So burnout, a lot of us have heard of and maybe experienced. It's chronic exhaustion and feeling detached from your work. Compassion fatigue is similar, slightly different. It's often called the cost of caring. It's feeling exhausted from being compassionate to others for an extended amount of time. Moral distress is a little bit different. For this one, consider COVID. It's times when you have to act not according to your own morals or values. So during COVID, having to implement visitor restrictions for patients and families at end-of-life care, that may have gone against, your own personal values or ethics system. And finally, vicarious trauma. This is also sometimes called secondary stress. This results in a hypervigilance or difficulty feeling safe. So we have a constant exposure to car accidents, gunshot wounds, violence. And that exposure can make you feel like you're at a higher risk or your family's at a higher risk of getting into an accident or being the victim of violence or an illness if that's the population you work with. So we're most vulnerable to what we're most exposed to. And so that's why trauma-informed care is important to protect us from these impacts. And how does it do that? So first, it's all about recognizing that we have this exposure and identifying any symptoms that we may be experiencing any distress. And through trauma-informed care practices, we're able to move to support and recovery. So if you are a Atrium employee, you should know that you have access to Headspace as part of our new benefits, which provides mental health resources, coaching, and counseling services. So we have to take care of ourselves in order to continue to do this work. So we have a few additional resources we want to highlight if you found today's topic interesting and want to learn more. So the first is called What Happened to You? It's a book by Oprah Winfrey and Dr. Bruce Perry, and it's written as a dialogue conversation between the two of them. The Body Keeps the Score is a really popular book in our field, talking about the physical impact of emotional trauma on the body. And then Healing Mean and Bone by Bone are both stories written by trauma survivors. And finally, the QPR training, Question, Persuade, and Refer, is a suicide prevention training. So if you're interested in that training, let us know. We can set up another training. I'm going to move past the references. And I'll pass it over to Jesse in a second to facilitate any questions. But we also have this post survey here. So if you will please scan that QR code, we are curious to see how you may implement anything you learned today. So just a few additional questions there on that post survey. We'll leave this screen up. Thank you.
Thank you, Chloe and Kayla. So I wanted to give everyone a couple minutes here at the end to ask any questions. I think Scott's going to help me with the folks in the chat, right, Scott? But if anybody here in person in the auditorium today also wants to ask questions, I'm handed the back and it's Scott.
So I'm guilty of this as much as anybody, but I see frequently in patients' charts, the patient is a poor historian. And you may have mentioned this, I'm sorry if you already did, but what are your thoughts on using that terminology?
That's great.
The patient is a poor historian.
Yeah, my first question would be why? What is the barriers that are making that patient a poor historian? So the things that we look for, and if you guys want to add in, feel free. But the things we look for are first medical reasons why the patient might be a poor historian. Are they suffering from dementia? Do they have some sort of brain injury that is a part of their injury why they came in? So they might have a medical reason to be a poor historian. We would look at that first. Were they intoxicated or under the influence of some sort of substance when they came in? I think that would be a reason why we might not know the full picture. If I saw that, my first thought would be to understand that I don't know the full picture of why that patient is coming in. So they really might be a poor historian. So do we have another opportunity to get the history from that patient? I love someone who said, listen to the chaplains. We have a bunch here in the room. I might pull up a note from somebody who might have already built rapport with that patient. So I might look to see if there has been someone who has gotten a better case history than whoever wrote that initial note, and then look for opportunities to get a better case history. And if that's not possible, just know that we don't have the whole picture and that potentially we might not know all the reasons why that patient has come in, and treat them with as much trauma-informed care as we can without knowing the full picture of what they're dealing with when they come in. It's a great question. You guys want to add anything? Okay. Anybody else have a question online or in person? Yeah.
Evet.
Mhm.
Evet.
Yeah. I'm going to repeat what you said just so the folks online can hear, but the statement was that the system has created the barrier, that the medical providers are needing to
Doğru.
document
Cevabı
something
evet.
about why that case history is not there. So if y'all,
Tabii tabii doğru.
so
Doğru.
if you're putting that the patient is a poor historian or that they're uncooperative, it allows the chart to reflect that the provider attempted to get that information. That's what you're saying. Yeah. And so the question, I think you guys had mentioned it, that understanding that systemic issues exist, right? So if that is something that you can't prevent, and potentially you can't, because we're not here today to say blow up the whole system and change it. As a reader of that chart, I would say understanding that the systemic issue does exist. It might just be as simple as that. That trauma-informed care exists because we cannot always change the system immediately. So do you have an opportunity to, if you write that, maybe add to it later? And or if you're reading a note that says the patient is a poor historian, the patient is uncooperative, you yourself are a trauma-informed care provider. Why does that exist? And can you go into the room understanding that you might have a bias because that note exists? So I think that's a real opportunity for providers who are getting trained in trauma-informed care. We're not going to go out and change 100% of the system. And you have a really good point. It's going to have that. Those notes are going to exist because you're protecting yourself as the provider. But what you can do is say, hey, there's a reason this exists. We know that patients are coming in with a trauma history and their own barriers to care. And so how do I walk into that room knowing they were uncooperative, but there's a reason why, right? Not what is wrong with you, but what happened to you. Asking yourself that question before you walk in makes you a better trauma-informed care provider, even if the system is working against you. What else we got? Scott.
Kind of similar to that last question. You said to avoid labels, and it's easy for us to write that the patient is experiencing schizophrenic-like tendencies or appears to be intoxicated, but that's a specific thing. Is it better to use descriptive words or like to describe that behavior? Because that, in my mind, I could be wrong. That's pretty unique. Those behaviors they're exhibiting. So I may not be able to diagnose them with that because I'm not that particular specialist, but if they're experiencing schizophrenic behavior, I'm going to label it as such.
Yeah.
How can I better define that?
So I would say if the patient is diagnosed with schizophrenia, I might write that in the chart. When I used to train on documentation and making sure that, especially with students, they're judgmenting in non-judgmental ways, the most simple way to do that is document exactly what you're seeing. So schizophrenic behavior could mean something really different to different people. But for example, if somebody comes in and I'm reading a note that says the patient was sad. What does that mean? Was the patient crying? Did they have their head down? Was the patient sleeping? Did they have a blanket over their head? Did the patient tell you they were sad? It's as simple as just documenting exactly what you saw and not making a judgment about what you think that behavior means. So the patient had tears in their eyes. The patient was crying. The patient stated, Scott, I'm sad today. It's as simple as you not determining what that patient is feeling, When I talk to a patient, I call that a distancing phrase. I usually won't say, you feel sad. I'll say, it sounds like from what you're telling me that you're feeling sadness. Am I correct? And I'm distancing my judgment and I'm asking them to clarify. So you could ask them if you have that opportunity, or you could write as simple as what you're seeing, right? If the behavior was erratic, what is the behavior you're seeing, right? Were they talking to themselves? Were they talking to someone you couldn't see? Were they, was their body having symptoms that you're noticing? I would write that down instead of the patient appeared schizophrenic. Not sure. Were there any questions online or any more in the room? Anything else? Great. Well, we'll hang after for anybody who's in person and wants to chat. One last reminder to fill out the post survey. So Chloe can graduate with honors. So we're really glad that you guys were here today. Thank you so much to Kayla and Chloe. They worked so hard on this. And I think this topic is just so incredibly important to the patients that we serve and to you all as providers. So one more thank you for them. And don't forget to do your final QR code survey.
And just reminders, lots of links in the chat. There's different surveys. One is the post lecture survey to kind of see gauge what you've learned from this lecture. There's also a separate evaluation we ask you to fill out for CME and such to say overall, how was the experience? And again, as Dr. Green said, don't forget about our upcoming trauma symposium on May 14th and 15th.
Great. Thank you.